Right. Thank you for the invitation. So, I'm a neurosurgeon in Paris, so don't be sad about it, but I feel always a bit alone in the robotic audience. Alone because of that, but also because unfortunately I didn't have some patients in my hands and I'm presenting some cadaveric studies, but next year it will be okay. So, I'm talking about the torso surgery for my field, I mean the skull base. So just a bit of anatomy for you that can be maybe far away. This is a skull base with a sphenoid bone, and just inside of it you have this hair cavity that is called the sphenoid sinus. And just at the top of it you have the pituitary fossa, which includes the pituitary gland and the tumor I am involved in. Of course, this is the work I've performed with Stefanos and also Michael. I have no conflict. So as you can imagine, these structures are very deep and in narrow spaces. There are two main techniques that have been described. The first one, microscopy, is now a bit old-fashioned, but you go into the nose under the mucosa thanks to an incision under the lips. For maybe now 20-30 years, the gold standard of this pituitary gland approach is the endoscopy, transnasal. We have some very nice results with it and a real minimally invasive surgery with great vision, but we can also challenge it and try to show some disadvantages, such as sometimes we have to resect and remove some endonasal structures, such as turbinates, septum, etc. You only have a 2D vision. And the major pitfall of it is the water tightness problem, because when you have a defect into the skull base, you have a CSF leak and the risk of meningitis, etc. So thanks to this, and with my old friendship with Stefanos, we had the idea just to change the axis of the video endoscope. He works for his this way, and so why not try to put the endoscope this way, so that we have a vision into the cavern and maybe on the skull base, and try to improve our techniques because of the usual advantages with the Da Vinci. So we performed that on cadavers. This work was made at the École Européenne de Chirurgie, located in Paris, with the 4-armed robots, but usually we can only use 3 arms in the oral cavity. We totally performed 10 dissections, and we of course use, as the neural navigation is not so easy for us, a fluoroscope on a sagittal plane. So this is the 4 sequences, of course the setup, the mucosal dissection with the robot, then this time drilling, that cannot be actually made by the robot totally, and finally the closure. So imagine that normally we take this way, and now we try to make this one. So this is how the room is set. On the contrary to head and neck procedure, the robot is just behind the patient. You have here the radiographic control, 2 surgeons as usual, and you can see in the picture here the 3 arms inserted into the mouse cavity after retraction, and after also a soft palate retraction. So actually this time was quite easy. It's just some robotic approach. It took 10 minutes, and you have this kind of view into the cavern. So this is the soft palate retracted. This is the choane. Here, the vomer, which is joined with the sphenoid here. We'll have a better view here with the 2 wings of the vomer. So just for you to understand, this is the area of dissection with the robot. And as I just mentioned to you, we have a different axis of view, and we have actually a real inferior view of the sella turcica. First, we designed this kind of mucosal approach in an inverse U shape. but lastly, we prefer to perform a real U-shape incision because we can, after that, insert the flap into the sinus sphenoid if you need, and in case of any CSF infection. So, by that time, we have to drill, and we don't have any instrument for that, except one prototype that is maybe hidden in a place in San Francisco, I don't know. So, actually, this time was made by me at the bedside. And actually, with some specific drill, if you put the drill into the labial curvature, you can have access to this region, which is quite mysterious for many neurosurgeons, anyway. So this is the key point to enter the sphenoid sinus, just at the joint between the vomer and the sphenoid, just this point. And this is a very easy, it don't take 30 minutes. The whole procedure takes 30 minutes, but this one is quite quick. And you have this kind of view of the sella turcica that is here, and the corresponding sagittal view with radiography. And so this is a totally inferior view. So just a short movie to show you that it's quite near actually. You have here that, sorry. Let's move to make it again. So the hard palate, then the soft palate that has been retracted. And here's the hole. You have here the base of tongue that can be bothering a bit. The les trompes d'Eustache. The nasal cavity are here, and the flap is here a bit retracted by coagulation. And this is your final view of the pituitary gland just behind the bone. From then we drill to obtain and to see the dura mater. Then we can insert the instrument into this cavity to coagulate the dura and then open it. And of course on cadavers we didn't found any adenomas or tumors, so we just removed the normal gland. And the normal gland is this kind of tissue, yellow tissue color. So we removed it with the robot quite easily, even if we don't have the proper instrument. And at the end of the resection, you can see the pituitary stalk here and the optic chiasma just under. Sorry for that, it's just maybe a picture you don't see usually, but anyway. And so at the end of that, we talk about closure. It's not so easy to perform suture in this very deep field. But thanks to the flap, we can insert it very close to the pituitary gland. This is this picture. And in case you don't have any CSF liquid, you can just suture it into the cavern. First, we had some ideas of free flap, but it's not so easy to work in progress. So, from this 10 cadavers study, we have promising results. And despite anatomical variability, we have men, big, women, etc. I think this is the real minimally invasive procedure comparing the endonasal one that can be sometimes a bit tricky with empty nose syndrome, rhinitis, etc. And the big thing is that we really change the axis of work for this tumor. In case of big supracellular adenoma like this one, when you go this way, it's probably not so easy to get here. But if you use a robot going this trajectory, this can be easily seen and maybe easily removed. So, of course, we published it, and we have some great perspectives. The first one, of course, to make some patients. So I think next year we'll have our first clinical study. We also continue to go with cadavers, just to see the exposure limits, for example. Just for fun, we go into the brain with it, and the third ventricle. We discover the the basilar trunk here. All this work just to try to find new application in my specialty. For example, with Stéphanons, we performed a drilling of osteophyte, bony osteophyte of C1, C2 joint. So This is possible, but we hope to have a fully robotic procedure. So try to find some bony instrument that can be probably feasible thanks to intuitive collaboration. And we hope we can insert the Da Vinci procedure into this little Excel, just to imagine that the vision would be good. We have a 3D dimension with great manageability of instrument and very, very low invasiveness. So thank you for your attention.